to build your skills in telephone video consulting. And it is a webinar especially designed for doctors working in aged care settings, but of course is applicable to anyone who's working in telehealth at the moment. Before we begin, I would like to acknowledge the traditional owners of the land that we're all meeting on today and acknowledge their continuing connection to land, waters and culture, and pay my respects to their elders past, present and emerging. We've just got a few very brief housekeeping slides for you to go through. The first one here is just to familiarise yourself with the Zoom instructions. Please make sure you know how to mute yourself. Just a reminder, if you could all please remain on mute unless you have a burning question to ask. Sometimes there can be background noise that you're not necessarily aware of that can cause some difficulty with others listening. And it's up to you whether you have your video on or not. There are some instructions over there at the side, as Madeline mentioned earlier, as people were coming on. If you could please use the participants section of the column on the right to change your name if it doesn't match your registration. Sometimes, you know, there are multiple people living in a household. It could be somebody else's Zoom account, but for us to acknowledge that you were here today, you would need to change it to your name. So there's some brief instructions there, very simple. And we do ask that you use the Zoom chat function. You're welcome to pose questions at any time into the chat function, and we'll be compiling them to ask. And hopefully there'll be time at the end as well for any audio questions you'd like to ask either of the presenters. We just thought while we have you here, we'd let you know of a couple of other upcoming COVID webinars that we have going on. So managing mental health distress in general practice, 22nd of September, and also managing COVID positive patients within primary care series on the 29th of September. All of our education sessions can be found on our website through the events page if you are looking for them. And finally, from me, I'd just like to extend a very big thank you to our two presenters this evening. We're going to start with Dr. Jagdeesh Dhaliwal. We are very privileged to have Dr. Dhaliwal as the chair of our Aged Care Expert Advisory Group here at Northwest Melbourne Primary Health Network. And Jag is a Melbourne GP who's been working predominantly in aged care. He's got over 20 years experience running telephone consulting training for GPs, both in England and now does a lot, of course, in Australia as well. And our second presenter this evening is Dr. Atish Manek. He's a general practitioner, again with over 10 years of general practice experience and now working full-time in the aged care sector. Prior to that, he also worked in the UK, and we are very grateful to have them both here today and to be running our webinar. And I will pass over to Jag. I'll just stop sharing my screen for you, Jag, and you can move on to your presentation.
Thanks, Sue. Let's just see. Does that display okay, everyone? Is that displaying all right?
Looks great.
Yeah, that's good.
That's great. Thank you very much. Hi, good evening, everybody. So my name is Jag Dhaliwal, and really pleased to be here presenting with Atish on telephone skills now. So the first question is, why do this? So obviously COVID has meant that we've had an upswing in needing to find different ways of connecting with our patients, and that's really impacted on all of us, particularly here in Australia, in Victoria, but I think in other states as well. We're just understanding that we need to have different ways to be able to connect should a COVID outbreak arise. So why sort of spend time on telephone consulting skills? Well, it doesn't matter what level you're at. I think the idea is you're continuously trying to get better. Whether you're just starting out or you're already competently using telephone or video consulting, there are always skills to learn. And that's really the purpose of the webinar, to be able to share. I'm going to share my perspectives, Atish is going to share his, and we're looking forward really to hearing your hints and tips as well. So it's a way of just trying to build a community of practice around this really important area for us. So the way I would see it, there are 3 key elements to successful telephone or video consulting. The first part is adequate preparation beforehand. Then there's a consultation itself. And then there's a preparation for follow-up actions, particularly things like being able to electronically generate drug charts and sign drug charts for facilities. So I'm going to just touch on these in order. So first thing I'd say is, in terms of setting yourself up for success, one of the reasons why it can be so stressful consulting for aged care facilities, I think, is because we have so many different ways in which the facility nurses are getting in touch with us. So they might be phoning you, might be sending you texts, might be sending you WhatsApp messages, might be emailing you, maybe they even write to you as well. And it can get completely overwhelming. And the idea here is to try and really get rid of all that clutter and just have one streamlined way of facilities being able to contact you. And this is something that my team and I found absolutely critical in order to be able to set ourselves up for success in video and telephone consulting. So there are 2 ways of doing this. Now, the first thing might be to set up an online collector, and I'll show you what we've done on our practice website. Alternatively, because I also, as well as consulting through a bigger group of GPs called Aged Care GP, I also, like a lot of you, see patients on the way back home from my surgery. So you can also look at things I've set up on my email. So I'll just start off with looking at what we've done corporately at Aged Care GP. So what we've said to nurses in aged care facilities is, we'd like you to please stop now contacting us by telephone, email, any other format. We'd like you just to use this one format, which is to go to our website and then to click book telehealth appointment. And then there's this form which the nurse will fill in, which we've designed to keep as simple and streamlined as possible. Really just asking for the nurse's name, facility details, their email address, and then describing the situation, the background, and then critically asking them to send us a drug chart. And also we've added in a feedback loop here as well, just to check that facility nurses are finding this process, relatively agreeable. And actually so far the feedback has been very positive. And the reason we're doing things that way is to try and avoid things that I'm sure has happened to you. You'll phone up and speak to a nurse in an aged care facility, and then you find that you're waiting around for ages for the drug chart. You can't do anything until that's happened, and you never really get to complete a consultation. By setting yourself up, stacking the cards in your favor by having that information up front, you have a much better chance of having a successful outcome for the patient and for the facility. The other thing you can do is, if you don't want to set up a collector like that, is set up an out-of-office message. So feel free to email me either at jag@agedcaregp.com or contact drjag@gmail.com. You'll get my out-of-office email message, which does pretty much the same thing. It very much streamlines the information that I would like from the aged care facility in a very structured way. And the particular structure that we're working to, oh, sorry about that. Let's go back. There you go. So the particular structure we're using is the ISBAR handover protocol that's used. So we're trying to make sure that we have the identity of the patient, the description of the situation, and this typically will include observation. So we're asking facilities to do all those things like oxygen saturation, maybe get a BGL done as well before they contact you. Some background information, and this is a part where you might find that in fact prior to having the consultation with the patient, you might want to give the family a call, and then some idea of what sort of action do the facility want you to take, and the response as well. So just a nice structured way of ensuring that there's good handover between the facility and you. So we try and use this as a format that the facility will use when they're communicating with us, but also as a way that we will communicate back to them, just to keep things very tight, neat, and structured. Next part of preparing for the telephone consulting is to do all of this. It's the human aspect. So I love that research that shows that people can tell if you're smiling on the phone. They might be able to see your face, but they can tell what sort of mood you're in. And remember, you know, facility staff are often quite stressed, particularly if not used to doing telephone or video consulting. So just remember to get yourself into the right frame of mind and smile. Smile on the telephone, because people will pick that up. And just remembering to keep our own patience and really encouraging members of staff to engage with us, and just thanking them for the time they're taking to video consult or telephone consult. So let's start off with the consultation itself. So for the telephone, I'd say that it does have quite a lot of advantages. So I wouldn't necessarily say video always is number one for our aged care residents. Advantages of telephone? Well, first, it's much easier to hear the facility staff and also residents. And one tip that I've picked up is maybe starting off on the telephone to get that oral history from the facility staff member and also from the resident, and then you can flip over to video to eyeball them. And remember, the other thing you can do here is ask the facility staff member to maybe text you photographs, because often the photograph is much better for looking at things like rashes or wounds compared to a video consultation. And then, as well as getting the history by telephone, remember there's so much we can do in terms of physical examination as well over the phone. You can tell if somebody sounds short of breath, whether they're wheezing, are they articulating their speech, are they slurring, do they sound as if they're in pain? You can make an assessment of their cognition, are they orientated or confused? And also, I think you do get a good sense of their mental health as well. Do they sound anxious or depressed? There's an awful lot of physical examination findings you can pick up on the phone. Also, in terms of examination, asking the staff member to physically examine while they're on the phone to you. You know, you can ask them to palpate the abdomen. So sometimes what I've done is I've asked the facility staff member to hand the patient the phone and ask them to palpate the abdomen. And I'm listening out really for any sounds of pain really whilst they're doing that. And similarly, you can do that with a post-fall situation, asking the person to maybe stand up, listening for sounds of pain. It's just other useful information that you can gather. One quite good tip I found is asking the resident to walk and talk. I find that's a really good way of trying to assess if the patient's relatively well. Obviously, this applies to a patient who normally can walk. But again, just useful physical examination information you can get from the telephone. So just a reminder here, you do remember photos. Facility staff, maybe agency staff who aren't really that comfortable or familiar with having a video call you, may be more than comfortable to contact you via mobile phone and then send you photos. So that can be really, really useful. And one thing I found pretty useful these last few weeks is three-way conversations. So a situation might be a resident who is unwell and the facility and you are unsure whether the family would like the patient to go to hospital, say, or maybe just want to get some collateral information. So one thing I found incredibly useful is to make sure I've got family member details saved to my phone. These are particularly for patients who are frequently unwell. And then what happens is the facility will call me and then I can click on add call and then merge in a telephone call with the family member. And you end up having a really, really useful three-way conversation with you, the facility staff member, and the member of the family. And you can make a good decision that way. Another time I've used this is for in-reach conversations with geriatric in-reach services. So it might be me, geriatric in-reach, and the family, where we're really just talking to the family about the pros and cons of hospital transfer and what this might mean. And again, you can get a decision made quickly. It's time really well spent. So that was telephone, and how about video? So as I say, you do get sight, but maybe sometimes I've found it's expensive sound. So is it worth maybe trying to flip over and use telephone before you use video? I'd say that if the audio isn't good, remember to speak slowly, short sentences, all the things I'm sure your English teacher told you to do about articulating really well, and making sure that you're not speaking in highfalutin English, because you want to just keep things very intelligible for people, and that's absolutely key. And maybe just agree a format for the round as well. One thing I found is on the video, often the nurses will want to rush into the room with the iPad and get you to see the patient. Whereas actually what I would like is for us to have a chat first, just to understand what the situation is in more depth, and then go into the consulting room. Remember, if you're doing a big video round as well, to just periodically thank the staff member and check that they're okay. You know, that can go a long way just to keeping their batteries charged and keeping them motivated. And also give really clear instructions about what you would like to see, because that is a skill that they're trying to pick up from a facility point of view. You know, so clear instructions around, could you please point the camera just up at the head? I'd like to just see the patient's head, just the back of the head. You know, it's very clear about what I'd like to do, and that way then the staff member won't get frustrated, but just clear, short, clear sentences that staff can understand. Video, of course, you have more opportunity to examine. You can get an overall look of the patient and really just do a head-to-toe type of examination of what you're seeing with the patient, and getting all of that recorded, of course, as well. In terms of telephone or video, what I would say is act on your instincts. Act on your instincts. Much like our face-to-face consultations, if you feel at the end of the consultation that you're really not quite happy about things, you can call back. You know, you can call back an hour later, you can call back later on in the day, just to double check on things. You can maybe even schedule in a second appointment just to be able to check on that patient. A good idea, I think, to always elicit from the patient and staff who know the family well their particular ideas, concerns, and expectations for this telephone consulting, and also to engage shared decision making, which of course is part of good quality care across the board. One particular situation that I've really found challenging in terms of telephone or video consulting was shortness of breath, because of course you can't auscultate a chest. And it was good to talk this over with the hospital inReach team, because they've been saying that, to be honest, in the midst of COVID, they haven't been going in and listening to chest because of the risk in terms of infection transfer to them. So really, it's here about making a reasonable judgment of what might be going on. So if the patient's short of breath, do they have a past history of asthma, frequent LERTs, left ventricular failure, or ischemic heart disease? To get the history and look at the oxygen saturations, respiratory rate, and from that then make the diagnosis of whether it's infection, COPD, or LVF. And really, you know, given the challenges in the situation, a reasonable course of action may well be to cover all your bases with antibiotic, steroids, and maybe a diuretic as well. And I think since I've got my mind around that and understanding that inReach really is examining patients from the end of the door if they're thought to be COVID positive, it's probably a reasonable kind of action to take in that situation, given the need to balance the needs of the patient with the risks of infection spread. In terms of follow-up actions, so just in terms of time, this is something I'm not going to go through now, but I have just prepared a video on the ways in which you can set up to electronically print and sign drug charts, because this is a really important part of getting set up that I would encourage you to do, and get it done early, because it's a bit clunky to be able to do that. But once you've got over the initial hurdle, you'll get better and better and faster at printing drug sheets, signing them, and be able to send them electronically. So those were my hints and tips, and it's now time to hear from Atish. So thanks very much, Atish. I just need to stop sharing, I think.
Jags, thank you very much. Appreciate that. I'm just going to build a little bit upon that. So, evening, everyone. Thank you for taking the time to join us this evening. I think Madeline's kindly putting up my presentation, which is much appreciated. My name's Dr. Atish Manek. You can probably tell from my accent, I'm a UK GP. So the reason I was asked to join this evening was essentially that prior to coming to Australia, I worked in a practice where we trialed a doctor-first model, and the concept there was that we telephone triaged every single patient contact and then allocated appointments accordingly. So having done quite a breadth of telephone triaging, I'm going to share with you what I do currently with telephone and telehealth consultations, and hopefully it helps some of you this evening. So next slide, please, if you could, Madeline. As Jag stated, preparation really is the key. And I guess the first thing to start off is about picking which software you're going to go with. So the department has said that you can use software such as Zoom, Skype, FaceTime, and of course there are others available. And currently, I tend to go with whatever the facility is using and comfortable with. So although we do have our own platform that we use most commonly, I'm very comfortable to flex around the nursing staff capabilities. So some will have FaceTime, some have Zoom apps installed on the iPads within the facility. So again, be flexible and go with whatever they're comfortable with. But at the moment, the department has said that if video is not available, then you can offer telephone services, but they won't allow you just to do online chats or email consultation with facilities. The next step in preparation is to agree a schedule. So I have allocated a time and a session for every facility that I manage, and it's done by the clock, essentially. It's working really well because I get regularity and get to know the nursing staff accordingly. And for those that are going into facilities now, I very much can use the telehealth option as an on-call triaging mechanism, which I'm doing quite successfully, and encourage you to do so if you can. The next thing I've done is remote access. It's not just remote access to your own medical software, but actually remote access to the facility software. So it's taken a number of weeks, if not months, to gain access, but I do have now access to every facility software that I attend. So encourage you to keep pressing if you haven't maintained that yet. Really useful to check on observations and weights, and for those that are unwell, to get day-to-day feedback if you want to have a quick check. So useful mechanism if you can. Personally, I tend to sit with two screens in front of me. So in one screen, I've got best practice, which is a software we use, and the other screen is the video with the facility. So I can flip back and forth quite comfortably and check my documentation. Just a reminder to turn off your distractions, your notifications. In practical terms, what I tend to do is ask my nursing staff to liaise with the facility before I join, to create a handover sheet. So mine's a little bit more simple. It just specifies the name of the patient and a current sort of update. And then I start my ward round, as it were, by doing at the bottom a paper round, which is just discussing each of my residents with the nurse present, and then allocating time accordingly. So we know that nursing time is very difficult at the moment, and this way we can streamline the time that we have available and see those patients that need to be seen. So I find that the handover sheet just tends to focus our energy really successfully. And the other thing that I've done, and please do copy if it helps you, is create a spreadsheet of plans. So the way I structure my notes is I create in the plan at the bottom of my notes just a sort of ideas for following consultations that I want to follow up. And then I've created a spreadsheet with each resident on one side and just the cut and paste the plan into it. So when I'm going through residents on the paper rounds at the beginning of my ward round, I can very quickly look at what they've sent over on the handover sheet, look at my spreadsheet and see what I'm wanting to follow up on, and allows me a very quick way of just scanning through what's going to happen for the next couple of hours. Next slide, if you could, Madeline. And then there's the consultation itself. So just to reiterate that the patient has to be present in the consultation in some form. So you cannot just document a paper round and put that through. And you also need to document patient consent for that interaction. I tend to use a very systematic approach. It's made sure that I can cover all the main areas. And I found that for those who are best practice users, on the right-hand side of the screen, you'll note that there's that section for cardiovascular, respiratory, and the top of those boxes, there's the history section. And I tend to run through that history section very, very speedily. Allows me to focus my mind, but also allows me to very quickly document negative and positive findings. So for medico-legal purposes, that's really important. Just to remind you that you can use remote examination. So all the facilities will have blood pressures, oxygen, SATs, etc., etc. And so use those and document those. It's not uncommon for me to ask the PCAs during my telehealth rounds to pop up and just do those basic observations while I continue round with the nurse. Again, just streamlining time available. And on the top right-hand corner, from that very infamous BMJ paper about COVID telehealth consulting. So those are examples of remote examination findings which would lead me to be concerned for a patient with COVID that I was examining. Just to remind you of the importance of red flags, and on the bottom right-hand corner, again taken from that infamous BMJ paper, are the red flags that I would be using for COVID consultations. And I would document positive or negative findings from those red flags as well. Just moving through safety netting, something I'm sure we all do, but again, very, very important in your remote consultations. And I tend to write in the plan section of my entries safety net criteria to look for. So for example, for heart failure presentations, I'll document waits to contact me back again. So again, something that I hope you currently do. And then I'm finding that I'm having lots of family conversations at the moment, similar to JAGS, not only in the acute setting, but also for chronic disease management, and very useful in the remote section, the remote consultation space, just a plan for the future as well. So just moving through, Madeline, if you could. And just covering sort of minimum criteria for documentation. So currently advice from the defence organisations is that this is a fairly standard set that I've seen. So they'd encourage you to document the modality. So telephone, so video consulting is your first option. And if not, moving through to telephone and just documenting which one you've proceeded with. Of course, putting your treatment plan in. Info received looks very much at any pictures or observations and things that you've received ahead of time. So again, just putting that into your entry. And I tend to forward any pictures I've received to my admin staff to upload onto best practice as well. Just to document any advice given and anyone that was present in the consultation as well. So if family are visiting and they're present at the time, again, just make sure you've put that into your documentation. And of course, the duration or time spent in that consultation. Madeline, I think that might be it, but just double check. Yeah, that's it. So that's it from me. And I guess we open the floor to any questions or comments you may have.
It's difficult. I can't see much that's come up on the chat. So maybe if anybody has any questions, feel free to maybe put up a question using the chat function. Okay. So it's stunned silence, I think, at the moment. This is challenging. Oh, we've got a couple there.
Here we go.
When did current telehealth items cease? I think no one really knows the answer, do they?
No. So I think what I've read is that they're currently deciding whether to extend them beyond the end of the month, but I haven't heard anything yet. I don't know if Jags, if you have any inside knowledge around that.
No, again, no one knows. I mean, we know that our professional organisations are strongly advocating for the continuation of telehealth. I think it would be difficult to see telehealth not being continued, given particularly what we've experienced in Victoria, and it's going to apply to the rest of the country as well. But we all wait and see. But in the meantime, it kind of makes sense, I think, to make sure we have the skills to be able to use it. Option to use case conference medical item numbers. I can answer that question. So I think our team had asked MBS, and I think that the case conference was found to be, that it was found to be that you could use that you could conduct telehealth, because you're trying to get the team together. You just have to document it in the same way using the item numbers.
So yeah, I agree. I currently, yeah, I was just going to say I concur. So I do use case conference numbers regularly in the current climate, and it works really well. And it's quite useful to have geriatricians as your third member, feeding that back to family. It provides a really good holistic approach to care. So yes, I do it regularly currently.
I just don't know if you found, and maybe others have found as well, that's one aspect of care that's actually improved during COVID.
Yeah, absolutely.
Because I used to find it really hard, not just, our geriatrician colleagues are often very busy driving between different places. We were really busy trying to coordinate and get, the relevant people in the room, really, really difficult. I found it a lot easier because our geriatrician colleagues, they're not in the car quite as much, so they can be available. We can then get buy-in from the facility because they're more comfortable using video because we started to use it, and then we're involved, and then we've also had families involved as well. We've had some really, really good in-depth case conferences with better quality care, and I really hope that's something that we carry on doing.
Agreed.
Other questions? Difficulties getting path results uploaded. We can probably know that's standard practice anyway. So that path results get uploaded to any of our GP computer systems, be it best practice or medical director. That existed pre-COVID as well. What is your process of signing drug charts, telephone orders, or chart updates? That's from Jenny. So Jenny, I've actually produced a video on this. It takes about 7 or 8 minutes. Just check with the PHN colleagues. Is that a video I can share? Because I've actually got a link that we could just add up as a resource, Sue. Is that something that we could do? Brilliant, yeah. So I've got a pre-prepared video that just takes us through step by step the process that I follow, and I know Atish will probably follow something fairly similar, where using the GP computer system, you can electronically print and sign the drug chart and send it through. So we'll be able to do that.
So if I may, just a sort of just a quick on what I do. So I agree. I also have to tend to find that facilities are wanting us to use their own medication charts. So they'll email them to me. I'll sign them using software like Adobe. So sign them remotely. Just save it and send it back. And I'm assuming, Jags, that's what your video essentially shows. And that's worked very effectively. And I haven't had any issues with facilities with that. Telephone orders, great reminder to say that you can use telephone orders, and facilities are generally pretty good and allowing me to sign those off when I next visit. So that's worked quite well as well. Brilliant.
Yeah, it's pretty much the same for me. I mean, I think I tend to print quite a lot through best practice. Personally, actually, because I'm always worried I'm going to miss the telephone order when I go in, and that's just to do with me. So I tend to just send through a fresh drug chart. But I found that the good thing is most of the facilities are really up their game. A lot of them are moving to electronic drug charts anyway. So that's making life a lot easier for patient care. Other comments here? Any comments on narcotics and second opinion aged care? I use geriatrician review currently. That's a really good question. We've just had a discussion about that in-house, and we thought this would be a good way of actually getting, because the rate limiting step beforehand was getting another member of our team to be able to drive to a facility, whereas now, of course, they can do it by telehealth. So I think telehealth has really helped with that. So we're just setting that up, aren't we, Atish? I think to get so in turn, we're getting other colleagues within our team to do that. But I guess you could ask any other GP that's visiting to do that as well, which I think is great for quality care in terms of looking at opiate prescribing.
Indeed.
Okay. That's great. Sue's put up some questions too as well. Okay. So I guess my question is, anybody got any concerns or worries about using either telephone consulting or video consulting? This is so different, isn't it, from what we would have done pre-COVID? It would have been a live session and you have audience participation. But I guess we're all getting used to this.
Indeed. It's a skill to learn in itself.
It's a skill to learn in itself, yeah. That's good. Do you feel you can manage end-of-life care by telehealth? Go on, Atish, you go and I'll see what I think.
So that's a really good question, actually. I'm just trying to think. I found in practical terms that when the COVID outbreak started, I did spend actually quite a bit of time doing a bit of COVID preparatory work with families and having lots of advanced care plan conversations with families, such that if patients have deteriorated over the last few months, actually it's been fairly simple to have conversations by phone or by telehealth with families to update them about the situation. We've built on the conversations I've already had. And actually, for the most part, actually, it's been fairly manageable. I think I can think of the odd case where it's been more challenging. I've had to go in to unpack, but I think for the majority, it's been okay. But I think that's probably because I've had a lot of time initially with a preparatory conversation. So I've done the groundwork in that sense. I don't know if that helps, but that's my personal experience.
Thanks, Atish. Yeah, it's probably similarly to me. So I was really, I think, influenced by articles that said that we as doctors, nurses, other people working with people at risk, when we started to get that hunch that we thought somebody might be end of life, to just share the hunch early, and because that actually was something that families really valued. So I've had a few cases this past week where somebody who's previously well has been unwell. It might be chest infection, or they've just become delirious, sepsis for some unknown reason. And what I've made myself do is I've ensured that at that time I've called the family, talked about what's going on, and I always will say something like, well, there is a possibility that this could be mum or dad winding down, and that this could be the way things go. So we just need to prepare for that eventuality, and then just leave it at that, and let the family member then say what they think, and then you end up having a conversation about how this may go in a particular direction. Another thing that I found is really, really important in our role as GPs in facilities is at that stage, because of lockdown, if I think there's a reasonable chance somebody may be end of life, I'm asking the facility to make arrangements for families to be able to visit under compassionate grounds, and that's been really important. So I have, I've had that conversation, and probably 50% of my patients have got better, but the other 50% haven't. And the families have really appreciated that, as the GP, I've just been able to ensure that they were able to see their loved one beforehand. So I think that's really helped. And then the other thing is, having the facility to be able to prescribe all the end-of-life medications electronically. That's something that we couldn't do before the last 6 months. Somebody physically had to go there and write everything up. So I think that's really improved palliative care. So in some ways, I think there have been some real improvements, being able to use some of the remote monitoring and telehealth facilities we've got now.
Jags, there's a question around, have the facilities bought iPads that are currently relying on staff and WhatsApp on their phones? So my experience is that most facilities have got an iPad or equivalent purchased. I've had experiences when the iPad's locked away in the manager's office and the staff can't access it, particularly out of hours. And so we've had to revert to FaceTime or phones. I've had instances where the Wi-Fi in the facility that the iPad connects to just isn't good enough, and have had to revert to staff's own phones. So I think the key here is just being as flexible as we possibly can. So I tend to start my ward round, as it were, with kind of a range of options in front of me. So I've got an iPad, I've got a phone, I've got FaceTime, I've got a Zoom available, and I kind of just work whatever I've got going at the time. I think flexibility is the key, in all honesty. Good.
Question here about requirement for 3-month audits of antipsychotics with BPSD. I just see that as another consultation, so, and actually just linking into the next question. So a colleague just saying, yeah, this is useful, but I still like visiting my facility because people feel staff or contact. And I've said, I completely agree. So in my case, this isn't replacing face-to-face visits. It's more about having a blended model. So what I've been doing is, whereas I might have visited this facility twice a week, I'm making one of those visits a telehealth visit and the other one face-to-face, because you find you just get a different kind of a picture that way. Other facilities where I've got fewer patients, it might be that 1 week is face-to-face and the next week is telehealth. And the good thing I think about that is that God forbid, should there be COVID in the facility, and then you really can't go in, at least then you've trained yourself and also the staff to form a team to be able to do telehealth effectively. So one thing that we found, has been really challenging the past few weeks is where there's been a major COVID outbreak, where existing GPs haven't got telehealth set up, they've just not been able to provide care for their patients. And then teams like ours have been asked to step in to be able to provide that service. So I think, you've got to put those train tracks down beforehand just to make sure that you've got systems and processes set up. And I completely agree, it is clunky and not as easy to use the first few weeks. You've got to allow yourself a good 4 to 6 weeks just to get up to speed in terms of being able to use it with a particular facility. So, Atish and I are used to using this, but with a new facility, I don't find it easy the first couple of weeks. Did you, Atish? I mean,
no, I completely agree.
Yeah. And
there's
all our learning period and all our leadership and persuasion skills as well for facility. So I think another colleague said, they're finding it difficult for nursing staff to give input. So I would say, that's something that you build on. You've got to sell the idea to the nursing staff that, look, you're worried about a patient. If we do this, I can help you more quickly. Try and find out what's in it for them, how this is going to make their life easier. You've got to be able to do that and sell the idea. Not just expect that they'll drop everything and just do it because we think it's a good idea. It's got to be sold. And I think because I'm really convinced it can really help them and can help residents, because I'm passionate about it and can do that with conviction, I think people come on board. And has that been your experience?
Yeah, no, absolutely. So you were saying at the very start around not replacing face-to-face appointments. I mean, I think there was a period that we all stopped visiting facilities for face-to-face appointments, and it did replace it, but it took a lot of time to convince staff. And actually taking the time has meant that now the blend between sort of telephone, telehealth and face-to-face is working really well, because staff have generally run the gauntlet, they've seen the benefits, and it's working quite well. So it is worth putting the time in the long term. There was a question here about impress medications. I think that was from Jenny, I recall. So if you can manage it, it's a fantastic idea. I have to say, I haven't had much success in facilities willing to impress, particularly S8 medications. In fact, I'm trying to think if I've had success anywhere. I think the answer is no. Those who had impressed stock prior to going into COVID are the ones that have maintained it, but I haven't succeeded. So if anyone has any hints or tips that I can share, I'd love to hear them. I'm keen to put that into play.
Yeah, that would be really helpful, I think. So Jenny, I know, is a senior pharmacy colleague. So Jenny, anything you can do to champion that would be much appreciated from your GP colleagues. So I think ScoMo said 97% of Oz nursing homes have no COVID issues or concerns. Should we be careful not to overreact by changing our model of care? It's interesting. What do you think?
So my view at the moment is that I think it's enhancing what I give rather than changing, in the sense of I equally am trying to visit facilities maybe kind of once a fortnight, and using the telehealth now a lot of time for triaging. So it's added an extra bow to my extra string to my bow more than anything else. So I'm not sure I'd want to deliver telehealth care indefinitely as the only modality that I deliver my consultations, but I think the mix is something that I'm really enjoying. And that sort of takes you back to almost how I delivered care back in the UK previously, in the sense of you telephone triage a lot and see those that need to be seen and don't have to see those that don't need to come in. So I think it's a great mix if we can manage it. But I'm keen to hear your experiences if otherwise.
I'd agree, Atish. So if I think about some aspects of care, so remember pre-COVID, somebody had a fall. Invariably, the locum would be called, and we quite understand. Locum doctors aren't familiar with the patient. They'd be sending a lot of people to hospital. Now, I know, in fact, we know, because we've semi-audited it, haven't we, Atish, that we've been able, because of the regular doctor, we're doing maybe a falls review via telehealth. You're really, ensuring the patient's safe and saving unnecessary hospital admissions, which is, it's stressful for that patient. We all know what it's like for somebody who's stable, goes off to hospital and comes back and takes several days to just adjust again. And of course, it's a huge expense on our healthcare system as well. Much better to do it this way. So that's just things like being able to review acute cases in between my visits. I think that's been such an advantage. We talked about case conferences. I'm making, much better use of case conferences, and we've had some really good results, in combination with, like the geriatrician colleagues, or using other telehealth options as well from other specialities. So I remember for one of my patients who's got extensive renal disease, we got the nephrologist to have a case conference with me, the patient, and also her family as well, which would have been much harder to use beforehand. So this is enhanced care. Things like being able to manipulate the drug charts and work with those outside of the time you're physically at the facility is really useful. So people aren't, they can get hold of me, a member of our team, and then get palliative drugs written up fairly quickly, whereas there isn't waiting for me to get there physically or waiting for the locum to come in. So I think there's so many aspects that are really, really improved, and probably comes back to your point about having this as a mixed method. It adds to the quality of care we can provide. It's proper holistic general practice, isn't it? Most of us became GPs because we liked that ongoing relationship with people. That was typically the reason we picked this rather than hospital medicine, because I know hospital medicine, the aspects were interesting, but you never really got to know the end of the story, whereas it's so nice in general practice to have that ongoing longitudinal care, which is so important. I think telehealth enhances that, allows you to do it better. Next, pharmacists are required to undertake RMMRs. How can these be more helpful to you? I think they're always helpful. RMMRs.
Yeah, absolutely. I'm trying to think if there's anything. Oh, well, we have a fantastic audience that could probably pitch in any ideas. So please do put some comments in the chat box if you have any suggestions. I'm trying to think if there's anything that could be more helpful.
Yeah, I think they're always really, it's just good to get a pharmacist colleague's input, particularly around de-prescribing. That's always really helpful. In fact, actually thinking about it, probably would be good to get pharmacists involved more in case conferences with families. That might be, remember that's something that's more custom and practice in UK practices. We'd often have a pharmacist attached to the practice. And in fact, patients and families would go and see the pharmacist to talk through their drugs and medications. And I think we really could make a good use of that here in Oz as well. Getting pharmacists to be clinically active that way, talking to families, this is about us really recognising we're part of a team and not being territorial in terms of different professions as well, because we found that complementary. The pharmacists would just talk through medication options. That's all they were doing. Options with the patient and the family, and then the patient might then come and see me afterwards, having had a discussion, and we discussed then what might make sense. It just seemed to make good quality clinical care. Okay. We don't have any more questions coming up. Okay.
Just a thought, if I may, just following on from the RMMR. I suppose when it comes to things that are more helpful, I think one of the things that I found tricky is, for example, patients, sort of dialysis patients or renal dosing medications, when you need an instant bit of advice. I suppose historically I'd ring the local hospital and try and track down a pharmacist that can support. But I wonder if there's something in the community that we could tap into for those sort of more complex patients. Just coming on from the RMMR question, is that something that would be helpful in the future?
Yeah, God, that's a brilliant idea, Atish. Yeah, that would be really good. So the things that are standard care, of course, you tend to ring the dispensing pharmacist.
Yeah.
But if there's more in-depth knowledge,
correct. The clinical.
Yeah, that'd be really good to ring a clinical pharmacologist. Who almost kind of help to look after a particular area. That would be great, wouldn't it?
Yeah.
Finish just saying we can do renal dosing, crushing tablets. Yeah, crush reports are always really helpful to request a crush report. That's really good. Okay. Any other questions? Anybody around the telephone and video consulting, or have we exhausted the topic? Okay. All right. Atish, shall we maybe leave it there? I think so. I guess just from both of us, thank you so much for attending. It was good to be able to talk about it. and let's just keep the conversation going. I know through the PHN, we're trying to just make sure that we have a community practice around these issues set up. So it would be good for us to keep on sharing our thoughts and ideas, because you guys will have some really handy hints and tips here that we'd like to hear about as well. So we'll carry that on. But thank you from both of us, and back over to you, Sue.
Thank you very much. Thank you all.
Yes, thank you all very much for coming along. I'll just remind you that we now have a section of our website for GPs working in aged care, and we've been really actively building up that section. I mentioned in the chat that we had recently put in some further information about using those Medicare case conferencing numbers for telehealth, and put a link that goes directly to the telehealth section, but there's also some other areas for GPs, and as Jag mentioned, happy to put up that video in that area. And if anyone knows other resources, we're just trying to be a useful hub of information all in one place. Thank you very, very much to Atish and to Jag for presenting this evening. I hope you've all found it useful, and thanks very much.
Thanks, Paul.
Good night.